Our next speaker is Dr. Louise Rose. We've heard from Louise twice today, where she spoke to us about communication in the ventilated patient and also, again, around cough augmentation. Today she's going to speak to us about melatonin trials, so please welcome Louise.
Thank you. And, it's a little bit ironic being the person who's probably got the most jet lag and it's 3 o'clock in the morning in London, where I should be. But anyway, so I'm going to just have this quick little session here, was asked to present on melatonin trials in the critically ill and what we know and what we're doing so far. So I have no disclosures. So what I'm going to cover in this little presentation is, again, talk about a little bit about endogenous melatonin, and it's a fantastic segue and great presentation we just had on sleep. Why we think that exogenous melatonin, so giving melatonin to our patients in the critically ill, might be useful. I'll talk a little bit about the evidence for melatonin in sleep, the evidence in delirium prevention and treatment, and some evidence in terms of ventilation and sedation outcomes. So, endogenous melatonin, it is a hormone. It's a hormone secreted by the pineal gland. A hormone means that it can't be patented by a drug company, so it's probably why there hasn't been so much research on it until now. So, as was nicely described in the earlier presentation, it is what regulates and synchronizes our circadian rhythms. So you can see there in the graphic that your melatonin production starts building up during the evening time and peaks around 4 o'clock in the morning, and then it drops off again, and so it's low early in the morning when you're supposed to be awake. So it helps to accelerate sleep initiation. I did have melatonin last night, actually. And it improves sleep maintenance and efficiency. And also has some anti-inflammatory, antioxidative and analgesic properties, which might also be useful in our critically ill patient population. So why do we think that giving our patients in the ICU might be useful? So there is good evidence that is telling us now that critically ill patients do exhibit abnormalities in melatonin metabolism. And so remembering that serotonin is the precursor for melatonin. So we know that we've got problems with our patients with their serotonin deficiencies, and we think that this has implications in terms of one of the contributors, and you can see from the graphic there are multiple, we think, contributors to the development of delirium. It was mentioned just before about the bright light, so the blue wavelength particularly suppresses secretion, and so the bright lights, the monitors, the blue wave light that we have in the ICU in the day and the night is potentially having a role. The ICU environment, we all know, it disturbs sleep because of the light, the noise, the need to give patient care and invasive monitoring. And so there is some evidence to suggest that in over 75% of delirious patients, there is disturbed circadian sleep-wake cycles. So all of this means that it's biologically plausible and a rational argument to give exogenous melatonin to our critically ill patients. So what is the evidence in sleep? So Siobhan mentioned some of the evidence in terms of other areas thinking about sleep, and this is the evidence in terms of for use of melatonin. So a systematic review published in 2014 looked at pharmacological interventions for sleepiness and sleep disturbances caused by shift work, which, as we all work in the intensive care unit, shift work is a reality of life. In this review, 2014 review, they identified 9 melatonin trials, and they said in this review that there was low quality evidence that it did increase daytime sleep by a mean difference of 24 minutes, and nighttime sleep by a mean difference to control or placebo of 17 minutes in terms of sleep duration. So even though there are 9 melatonin trials in shift work, really the amount of sleep that it's causing it to increase by is still relatively limited. And then in terms of the evidence for jet lag, a very old systematic review now, they identified 10 melatonin trials. 8 of these demonstrated that there is a reduction in jet lag when flying over 5 time zones. I've got no idea how many time zones I've flown over recently. So in terms of melatonin for the promotion of sleep in adults in the ICU, so this very recent systematic review that came out did include melatonin, looking specifically at sleep. And so remembering that sleep is very difficult to measure in the critically ill. So we can have subjective measures and we can have objective measures. And the objective measures are particularly difficult. It's very difficult to do polysomnography in ICU patients. There is reasonable evidence to suggest that actigraphy is not necessarily the best. We don't know that the best is the best. So it's very, very difficult to objectively measure sleep in the ICU. Subjective measurements are also very difficult because they require the patients to self-report, and most of our patients cannot adequately self-report their sleep. However, in the systematic review, I identified 3 studies that looked at subjective measures of sleep with melatonin, and again, very low evidence, and 2 studies that looked at objective measures of sleep, only 37 participants, and overall they concluded that there was no difference. But in reality, very small number of studies, very small number of participants, and very, very challenging to measure. I just put this in here as well, just to highlight to you, there is another Cochrane review looking at non-pharmacological interventions for sleep promotion. So here, again, they've got 30 trials now, so over 1,500 participants. But again, when you look at this systematic review, so if you are interested in the area of sleep, this is good to have a read of. They did suggest that there is some evidence that using earplugs and eye masks are beneficial and potentially have a role in reducing incidence of delirium, but again, the evidence is low quality and we need more work. So as I said, studying sleep in the critically ill is challenging. So evidence for melatonin in delirium prevention. So until recently, we didn't have a lot of evidence in terms of using melatonin for delirium prevention. There is this systematic review that was conducted in patients outside of the intensive care unit. Again, so only 2 years old in terms of this systematic review. There are 3 studies with a total of 265 patients in receiving melatonin, 264 in the control group. And you can see here that there is no clear evidence. You can see that the diamond crosses once, so there is no clear evidence that melatonin or melatonin agonists do actually have an effect on delirium incidence compared to placebo. So, what do we have in our critically ill patient population? So, we have 2 big Australian trials. So the ProMedic trial, so this is the protocol for the ProMedic trial. So this is a trial that is currently recruiting in Australia, aiming to recruit 850 patients with an ICU length of stay of greater than 72 hours. So remember, we're talking about delirium prevention. So in the critically ill patient population, it is very important to realise that sometimes it is very difficult to determine that delirium is not present before you start an intervention. So to truly be describing prevention, you have to first determine that delirium is not present. And so this trial took a very pragmatic approach because we cannot determine that delirium is present when people are sedated and whether they're unconscious. And we either have to make the presumption that they either didn't come into the ICU with delirium to start off with, and so we're presuming that they don't have it, or we're going to start treating them within the first 72 hours or so and start giving them melatonin, because if we leave it too late, they're going to have delirium and we're trying to prevent it happening. So this study takes the pragmatic approach that they're giving it to patients earlier on. They're giving a dose of 4 milligrams within the first 48 hours till ICU discharge or for 14 days. The trial is still recruiting. We don't have any results yet. This is the second melatonin trial of delirium prevention. again, being led out of Australia. And so this is giving melatonin for prevention and delirium in cardiac surgery patients. So remember, with routine cardiac surgery, we have the opportunity to determine that delirium is not present. So it's a lot easier in this patient population to say that delirium is not present and we are trying to prevent it. This is a trial that's enrolling 210 cardiovascular patients, and they're giving 3 milligrams of melatonin versus placebo for 7 days post-op. This trial has finished recruiting, is in the follow-up stage, so results will be coming. And this is our little feasibility trial that we're conducting in Canada. So we took the other approach from the top trial, and we said, if we're saying it's prevention, we have to demonstrate that delirium is not present. So our trial is a lot smaller, as it's a feasibility study. So we are only aiming to enrol 69 patients with an ICU length of stay, and we are confirming that they are delirium negative before we enrol them in the trial. So we have a very, very, very short enrolment window to get our patients in, and it's taking us a long time to enrol patients. And in this study, we're actually doing a 3-arm trial where we're comparing 2 milligrams to 0.5 milligram versus placebo. And again, we're giving it to ICU discharge or 14 days. So 3 ongoing randomized controlled trials, no evidence, no results out yet. What evidence do we have for melatonin for treatment of delirium? So again, same thing, so if serotonin is a precursor to melatonin, we think that serotonin is a problem. If we can fix this, can we treat delirium? There are currently absolutely no randomized controlled trials giving melatonin as a treatment for delirium at the moment. So this is a big gap in our evidence. What about other important outcomes in the critically ill? So there's this study that was a randomized controlled trial published 3 years ago now. So there is just over 80 participants in this trial, so it's a placebo-controlled trial. And they demonstrated, I can't remember which country this trial was given in, but they had a rather strange sedative regime here. And their primary outcome was dose of enteral hydroxyzine dose, and they demonstrated a difference with this, and they also demonstrated a difference in their propofol utilisation giving melatonin, and that was the primary aim and outcome of this trial. This other study, again, a quite recent study, they enrolled 40 patients in their study. They gave 30 milligrams of melatonin. I don't know if you guys are using melatonin in your practice at the moment. We tend to give doses of around 10. So 30 milligrams is a lot, and they protocolized their sedation. And this, again, quite small study, but in a very selective patient population, they demonstrated a reduction in length of stay with the use of melatonin. So really, how do we sum this up? So I think we're all thinking that melatonin has really good biological plausibility as an intervention for critically ill patients for both sleep, in terms of improving sleep quantity and quality, and potentially for either preventing, treating both delirium. However, our current evidence in terms of sleep is very low quality, and in terms of evidence for delirium prevention, we might have some really good results coming soon, which will give us a strong indication of whether there is a role for melatonin. In terms of treatment, we don't have anything in terms of evidence, so that might be a step moving forward. But you could see there that in the 3 trials that I presented ongoing for delirium prevention in the ICU, they were all using different doses. And we actually have no idea what is the effective dose in a critically ill patient population. So in reality, it needs to be titrated to individual response, and it's been demonstrated that critically ill patients have very different melatonin pathways. So we may need to be going back to the drawing board in terms of thinking about, well, how do we work out what is the best dose for this patient and titrate it to that patient's response. So thank you again for your attention.
Does anyone have any questions? Siobhan.
Thank you for a fascinating talk, really interesting with use of melatonin. I'm curious about the dosages and how people are coming to those particular dosages, given, I suppose, in a more healthy population that I might deal with, you're sort of looking to have a soporific effect around kind of 1 to 3 milligrams and maybe a chronobiotic effect at sort of 0.5. So it was interesting to see those higher doses.
So I think people are just guessing in reality. I think we've got very little evidence to guide us, and I know that in Canadian practice it's becoming more prevalent to use melatonin, but I don't think we actually really have any idea of what is the most appropriate dose in critically ill patients where we know their melatonin metabolism is completely out of whack and their circadian rhythms are completely out of whack. We actually have no idea. And so in a way, conducting trials at the moment, I think, is a little bit premature. I think there's a lot more work in terms of PKU work and stuff like that, and it needs to be done in the critically ill before we would really understand what is the best dose.
Hi. I can't help but reflect that it seems to me to be very hard to get definitive results given you've got such a wide range of dosing from 0.5 milligrams to 40 milligrams. And then on top of that, sleep is, as you pointed out, is a very rubbery figure to quantify in an ICU setting. And then on top of that, especially with the changes in how we're realising that sleep's important, different ICUs are going to be instituting different sleep programs across their various centres. So to try and pick out the effect of melatonin in all that is going to be a bit of a big ask.
It's going to be very challenging, and I don't believe, but I know in our trial we are not controlling for a sleep protocol, right? Because it's being run in 3 units. We know that all 3 units don't actually have a sleep protocol, a sleep hygiene protocol, and it's all a little bit random in terms of what patients get. So that's going on. But I totally agree. In reality, if you are trying to pull out the effect of melatonin versus other sleep interventions, but then again, sometimes we talk about bundled interventions and whether that's okay, right? That's okay. So if we want to give a best guess would be, using earplugs, using eye masks, there's sound masking systems now that you can employ, plus melatonin. If that results in improved sleep and less delirium, maybe we don't necessarily need to pick that apart because then no risk interventions, really. If you're adding in a bunch of risk interventions, then you might be wanting to more carefully pull them apart. But if you want to put them together and as a best evidence sort of multi-component sleep intervention, then I think that's okay. Yeah, exactly.
You may have actually just answered my question. I see melatonin increasingly being used because I think people think it's no risk or low risk, as opposed to it's got evidence to support its use.
Yes.
Is that actually true as far as the available evidence base that it is low risk?
It's got a very low risk profile of anything we give in the ICU. It's probably the lowest risk profile. So our trial it's a Health Canada regulated trial. So it is, and we have had to justify that it is a very low risk intervention. And the frequency of adverse events with melatonin, and their adverse events are limited to maybe feeling a little bit sleepy in the morning type thing, which when you're critically ill in the bed is not the worst thing in the world. It doesn't really get a lot more than that. Would you agree? Yeah.
Probably the worst thing that could happen is that you may mess their circadian time up.
Yeah.
But in the ICU, as you say, that's the least
Yeah.
issue, and to get some sleep is...
Yeah. So all the current evidence is a very low risk intervention.
had a quick question as well. With regards to all those trials, has there been any collaboration between them so that maybe you can pull the results afterwards?
It's going to be difficult, right? Because they're three very different protocols. So I don't think there's going to be any way to pull the protocols together because they're different doses. As I said, in the Canadian trial, we are definitively declaring there is no delirium present before we enrol, whereas the Australian trial is just putting them in regardless. And the other one is a CV surgery group with another dose again. So I don't know that it's something that's going to be able to do like a individual patient meta-analysis to pull them together, unfortunately. Yeah. Great, thank you.
Thank you very much.
Can we thank Louise, please?